And let's talk about that, in terms of resectability. I think that is also something that we've been talking a lot about, resectability and how do we determine which patients are resectable, and also taking into account whether they're medically operable. Let's talk about discussing that. And has that changed how you view resectable in this new era of perioperative and neoadjuvant strategies?
Now, I would love to address that. I think there's a tendency for people to be divided on this topic. And there's kind of a school of thought, like you need to define resectability up front based on how the disease looks when people present, and versus let's wait and see, kind of the idea of the kind of a bridge to a decision. And I am really strongly in favor of looking at how people respond to make a decision. I think it's okay to determine someone to be borderline resectable based on anatomy. If someone is physiologically not a candidate for surgery, then I think you need to take a clear pathway for a definitive curative option from the beginning that doesn't leave surgery kind of like, hanging out there. It's very rare that someone who is medically inoperable is going to become operable, and unless there's like a social situation or a reversible, unusual, physiologic thing. But I do think that as we have better and better systemic therapies for our patients, there are a lot of patients who may not initially be resectable and can become resectable. And there are a couple of reasons for this. I mean, it can be extensive disease that suddenly becomes much more reasonable. And if you want to be, really out there, it can be patients who present as, really concerning stage 4 disease and then become oligometastatic or become, have minimal residual disease, or it can be somebody who has really a simple situation where it's something that's invading a structure that previously is not resectable, now it is. Or it takes someone where it might initially require a pneumonectomy and now it's a sleeve resection or a lobectomy, and you didn't want to do a pneumonectomy, but you can do a sleeve or you can do a lobe. I think that lung resections are a little bit different than procedures elsewhere in the body, where the extent of a resection can dramatically change based on a response to therapy. And so I think it's critical to have surgeons involved early in the process, but also to accept that resectability can be dynamic. It can change. And we just all need to have the entire team involved at all steps of the game and to have honesty about what's possible. I don't think we have to promise patients one thing or another, but what we don't want is patients being started on a perioperative regimen without ever seeing a surgeon, or for a surgeon to say maybe resectable to kind of kick the can down the road. There needs to be very clear criteria for someone who is borderline resectable, what the reasons are. Like this patient would tolerate, a lobectomy with en bloc wedge resection of the superior segment. They would not tolerate a pneumonectomy. This is what we're waiting for. This is what we're hoping to see. Like there needs to be very transparent criteria of what would convert that person from borderline resectable to resectable. I think that's reasonable. I don't think just kind of kicking the can down the road is an acceptable strategy. I don't know. What do you all think?
Yeah, I want to ask you a question though. Has your sort of thought process regarding this evolved with the data from the new trials that we're seeing? Now we have multiple trials that have shown the benefit of either neoadjuvant or perioperative. Is that something that you feel more comfortable now with results of like Checkmate 816,
Oh
Checkmate
yeah.
77T,
For
Keynote?
sure, for sure. Because I think when Pacific came out, a lot of us were like, "Oh man, stage 3 is done for us. We're done with that. Like we're getting a narrower and narrower window." And it's almost like we've traded which things are surgical and which things aren't. Some of the earlier stage stuff, really early stuff, might actually be better with SBRT, but some of the more advanced stuff, when we can get it out and get a negative margin, it may be better for patients, to get rid of the majority of their cancer cells and to, address things, even though we talk about debulking as kind of being a dirty word, but to get rid of the majority of disease, we think is beneficial. And the information we get from pathology is incredibly beneficial in this era. So to understand with a perioperative strategy, if someone has a major pathologic response or pathologic complete response, or if they didn't have a mutation before and now they do, or how those mutations are changing, the pathologic endpoints that we can get from our pathologists are incredibly helpful. And we're able to help patients more and more through a combination of really hybrid therapies of everything the entire multidisciplinary team has to offer. So I think that all these new paradigms are giving us more and more benefits of having surgery as part of the whole regimen and our treatment armamentarium. So I'm eager to make any patient that is physiologically safe for surgery a resectable candidate if there's like a anatomic, really like kind of geometric way to make it work. And what do you think, Robert?
No, I agree completely. I think in the past, we were mostly guided by dogma. If someone had bulky into disease or multi-station into disease, we would automatically say, not eligible for surgery, definitive chemoradiation, and then maybe consolidation durva, based on the specific trial. But I think in the era of immunotherapy and targeted molecular therapy, we're seeing dramatic responses in patients and significant downstaging, which does allow us to consider surgery in these particular cases. I do agree with your comments that we need to have a multiple disciplinary discussion and define the clear, boundaries of, what is resectable, what isn't, and what are the criteria for the amount of degree of response that would make the patient resectable, because those discussions need to be had prior to the initiation of therapy so that the patient, oncologist, and surgeon all are on the same page in terms of what would allow us to proceed with surgery in terms of response rate. So yeah, I think it's a new era. I think we have to look at each patient individually. I think the new perioperative immunotherapy data has changed what we consider as resectable and what isn't. And I think these discussions, need to be had in a multiple disciplinary setting, and also, informed discussions with the patients.